Good afternoon and welcome to our congressional briefing and national webinar on the report, Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths, hosted by Trust for America's Health, or TIFA for short, and Wellbeing Trust. My name is Tim Hughes, the External Relations and Outreach Manager at TIFA. We would like to thank our speakers and audience for being with us today. Real-time captioning is provided today by Nancy Grinley of AI Media. For captions, click on More at the bottom of your screen with the 3 dots. Next, click on Closed Captions. We encourage you all to share your thoughts and questions about today's presentation by typing them into the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom of your screen. From there, select Enter when you are ready to submit your questions. And now it is my pleasure to introduce the moderator of this event, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She is a national equity leader with extensive leadership and management experience in federal government, the nonprofit sector, academia, and professional associations. As president and CEO, she leads TIFA's work to advance sound public health policy, address the social determinants of health, advance health equity, and make health promotion and disease prevention a national priority. Welcome, Dr. Gracia.
Thank you, Tim, and greetings, everyone. Thank you so much for joining us today for this important discussion on the mental health, substance use, and suicide crises that are facing our nation. As Tim noted, my name is Nadine Gracia, and I'm the President and CEO of Trust for America's Health. And I'd like to welcome all of you that are in attendance in our audience and to thank our esteemed panelists for participating in this briefing. We are so honored that you're with us today. Next slide, please. Our agenda for today's briefing includes an overview of the Trust for America's Health and Wellbeing Trust 2022 Pain in the Nation report that we released in May of this year. Access to the full report is available on TIFA's website at tifa.org, and we'll include a link in the chat so that you can view the entirety of the report. Each of our panelists will then give a presentation, and following their presentations, we'll have time for discussion and questions from the audience. Now, our goals for this briefing is really to speak to the substance use and suicide epidemics that are impacting individuals, families, and communities all across our country. And importantly, highlighting and calling for transformative and comprehensive investments, policies, and programs that focus on the underlying causes of these deaths and how we can promote mental health, well-being, and resilience in all communities. Next slide, please. So to share with you about the Pain in the Nation report that we released earlier this year, TIFA and Wellbeing Trust have actually been releasing this Pain in the Nation report series since 2017. This is the 5th year that we've released this report that tracks the nation's epidemics of alcohol, drug, and suicide deaths. And this year's report includes newly released data showing that more than 186,000 Americans died due to alcohol, drugs, and suicide in 2020, which is a disturbingly record number of deaths in a single year. And notably, it was the first year of the COVID-19 pandemic. What you're going to hear certainly from our panelists is really diving deeper into understanding the root causes of these deaths and how we as a nation can really take urgent action to address the mental health and addiction crisis that we're facing. Now, in looking at these data from 2020, although all groups except for adults ages 75 and older had higher rates of drug-induced deaths in 2020 compared with the previous year, youth and young adults, as well as certain communities of color, saw disproportionate increases. For example, Black Americans experienced the largest increase in deaths, and populations in the South and West also experienced disproportionate increases. Next slide, please. Now, there's a very real danger when we think about these trends, which have been going on for 2 decades, that they'll continue. The COVID-19 pandemic has impacted Americans in almost inconceivable ways, and many turn to substances to help them cope with the stress, the anxiety, the isolation, and the financial hardship that far too many families are experiencing. And so we've seen some of the direct and indirect impacts, which include more Americans being in crisis. There's a CDC report, for example, that found that emergency department visits related to suicide attempts by girls ages 12 to 17 during the early part of 2021 were almost 51% higher than during the same period in 2019. We're seeing worsening of mental health, where the US Household Pulse Survey found that approximately 1 in 3 adults reported symptoms of anxiety disorder, which is around 3 times the 2019 rate. We're seeing increased rates of substance use in both drug and alcohol use. And we're also seeing higher rates of drug overdoses, where preliminary data from CDC show that there's a nearly 15% increase in drug overdose deaths in 2021. So continuing this increase that we're seeing in drug-induced deaths compared to 2020. Next slide, please. Now, something that's important to note is that even before the pandemic, we were experiencing a mental health and addiction crisis. As I noted earlier in 2020, that there were more than 180,000 lives, more than 180,000 Americans who died by alcohol, drug, or suicide. And that's a 20% increase from 2019. And when we look at this across the past decade, that's actually a 77% increase. And when we look at the data, the increases were largely driven by deaths from synthetic opioids, cocaine, and psychostimulants, including methamphetamine. And as I mentioned earlier, there are stark racial and ethnic disparities in drug-induced deaths. For example, while all groups had higher rates of drug-induced deaths in 2020, Black people experienced the largest increase, 41% compared to 2019. When we look at alcohol-induced deaths, American Indian and Alaska Native people experienced the highest mortality rate and the largest increase in 2020. Now, it's really important, especially when we speak with regards to disparities that we see in the data, that we put this into the context of the longstanding structural and systemic inequities that have long impacted communities of color and tribal nations, and that they continue to face and experience. And these inequities were further exposed and exacerbated during the pandemic. For example, Black households were more likely to experience job loss and food insecurity. And American Indian and Alaska Native children were more than 4 times more likely to lose a caregiver compared to white children, which adds to the type of adverse childhood experiences, the traumatic experiences that these children can face. We have to affront really the structural racism, the discrimination and poverty, the lack of access to primary mental health care, and other social and economic factors such as lack of affordable and healthy housing or quality education that serve as these longstanding structural inequities and structural drivers that contribute to higher rates of health disparities among communities of color. Next slide, please. Now, while we understand that all Americans need support coping with the stressors that have been created by the pandemic, we understand too that people who are struggling with addiction or mental health conditions certainly need urgent support and attention. And we know what policies and programs work to prevent these deaths, but we have to really have the urgency to act. We need to invest in the policies, in the systematic changes that are truly going to create the types of conditions in which everyone can thrive. Now, our Pain in the Nation report that we released this year includes recommendations that fall really into 3 thematic areas and priorities. First, that we need and must invest in prevention. We have to promote policies and programs that are going to address those underlying social and economic conditions that are creating the poor health outcomes and really working to reduce adverse childhood experiences and the impact of trauma. For example, Congress should be increasing funding for programs at CDC to reduce adverse childhood experiences, to promote safer communities, and deter the risk of suicide. That schools should also be receiving new resources and increased resources to be able to increase substance use prevention, mental well-being, and resiliency programs. Secondly, we should be addressing the worsening drug use and overdose crisis by continuing some of the pandemic-related flexibilities for substance use treatment, such as directing efforts towards youth substance misuse and promoting harm reduction policies to reduce overdoses. And notably, as lawmakers and other decision makers continue or expand some of those flexibilities in treatment, we have to address the disparities in access by race, by ethnicity, income, and other sociodemographic factors. The pandemic certainly is a clarion call for this nation to assure that we address those inequities. And finally, we should transform the mental health and substance use prevention and treatment systems through improved data accuracy so that we know the populations that are being disproportionately impacted, and we can tailor our investments and interventions to support those populations. We need to increase community capacity, bringing services to where people are to be able to address these needs. And we need to further advance the integration of primary and mental health and substance use care. Now, we also know that stigma remains a challenging issue. And we should ensure, for example, that our federal government and agencies are working to address and promote positive messaging around mental health screening and treatment through the types of programs and initiatives that it leads, especially for underserved populations to be able to reduce stigma. And in addition, Congress should be supporting efforts to diversify the mental health and substance use workforce to ensure that culturally and linguistically appropriate care and services that are respectful of and responsive to the needs of all communities are being met. So as we can see, there is much more that needs to be done. And the time is now to act with a sense of urgency to address this crisis. So with this overview of our 2022 Pain in the Nation report in mind, it's now my pleasure to introduce our esteemed panel that's going to help us really explore these issues in further depth and have a conversation and discussion about where we go from here. Now, before we begin, just a note that we will be saving audience questions until the end after all of our panelists present. So just a reminder to please submit your questions in the Q&A box, and we'll respond to as many questions as we can during this session. I'm now pleased to welcome our esteemed panel. First, Dr. Ben Miller, who is the president of Wellbeing Trust, which is an impact philanthropy dedicated to advancing mental health, mental, social, and spiritual health of the nation. Dr. Miller oversees the implementation of the foundation's strategies and full portfolio of investments and partnerships to help Wellbeing Trust have the real world impact on America's mental health and addiction crisis. He's a nationally recognized mental health expert. He's presented around the world on the need to make mental health an integral part of healthcare, most recently testifying before the Senate Committee on Finance about the need for an integrated approach on treating mental health and addiction. Our second speaker is Dr. Arthur Evans, who is the CEO of the American Psychological Association, the leading scientific and professional organization representing psychology in the United States. Dr. Evans previously served in public policy positions in Philadelphia and Connecticut, where he led the transformation of their behavioral health systems and their approaches to serving a wide range of individuals with complex needs. He also held faculty appointments at Yale University and the University of Pennsylvania's Schools of Medicine. And he's been an author or co-author of over 60 peer-reviewed research articles and of numerous chapters, reviews, and editorials. And a major emphasis of his career has been equity and social justice. Our third speaker is Schroeder Stribling, who is the president and CEO of Mental Health America, the nation's leading community-based nonprofit dedicated to addressing the needs of those living with mental illness and promoting the overall mental health of all. She's a lifelong social justice advocate with over 20 years of experience managing organizations focused on mental health, homelessness, poverty, and racial justice. Prior to joining Mental Health America, she was the CEO at N Street Village, a nonprofit providing housing support services for women and families in Washington, D.C. And now I'd like to turn it over to our first panelist, Dr. Ben Miller from Wellbeing Trust. Ben, welcome.
Thank you so much, Dr. Gracia. And let me just begin with my sincere thanks to you and the rest of your talented TIFA team. For the last 5 years, this is a lot of work to pull together these reports, and you all have done an excellent job. So thank you for that. Each year we put out these reports. As the data worsen, it gets harder and harder to sit with the lack of comprehensive action, the lack of dose, the need that we need to make a difference. These reports have given us this unique platform to highlight the data, to show the trends, both at a national and state level, but really to consistently push for robust action that can save lives. So it's an honor to share the virtual stage with my friends Arthur and Schroeder, as well as you, Nadine. So thank you. Next slide, please. I want to begin with some brief comments, next slide, please, with a recognition of this moment and our role in it. As Dr. Gracia already pointed out, the data are quite disturbing. This is a moment for us to pay attention to those trends. We are the leaders at this time. With all that's happening around us, what actions will we take to help? It's our moment as leaders, as family members, as friends, to recognize that what's happening in our nation and to course correct, to do something of significance, something that can change this deadly trajectory that we're on as a nation. Today, I want to propose 3 ways that we can change that. Next slide, please. But first, I want to better contextualize the solutions. I want to remind us that we have created a fractured, fragmented, and overall disjointed approach to mental health and substance misuse. We treat these issues as different from all angles, and then we use policy to concrete in the problem. This has led to all kinds of ongoing problems for people on the ground. Even things as simple as connecting mental health to substance use disorder services is a major challenge, but that's just the beginning. Next slide, please. Case in point, getting access to care. You've heard it mentioned already once today. Arguably, this is the cornerstone of what we should be expecting from a healthy and functioning system. Yet the thing that people experience difficulty with the most is getting help when they need it. Remember, most people don't get care. And in the substance use disorder space, it's only roughly around 10%. So don't be tricked into thinking that simply refreshing much of what we have out there is going to change this. We have as many, we can have as many same-day access initiatives as we like, but when the person still has to go to a clinic or wait for their follow-up to be weeks later, the problem remains the same. We aren't where the people need us to be. Next slide, please. And the problem seems so large that the strategy of simply trying to put out a new fire as it starts isn't working. We have to adopt a different mindset, one that recognizes we should do all we can to help those in need today, while investing simultaneously, robustly in solutions that can prevent this issue from getting worse tomorrow. I want to use the remainder of my time to talk about those 3 promising solutions that I think can best address where we are in this moment. Next slide, please. First, I think it begins with us. I think we have minimized over the years the role that each of us can play in helping. Next slide, please. In public policy, we spend a lot of time thinking about how we need more money, more clinicians, more this, more that. But I want to challenge us to really think and rethink this question specifically around workforce. There are assumptions about where care is delivered that might be wrong. What if people want clinicians in different places, where they live, where they work, where they play? There is an opportunity right now to reimagine where the workforce exists. And these basic questions you can see here on the slide, they provide somewhat of a guide to how we can begin to think about workforce. Next slide, please. To give you one example, building off the excellent work of people like Dr. Vikram Patel and others, we've been participating with leaders and partnering with leaders and organizations around this concept of that we call community-initiated care. It asks us to consider, what if lay people were equipped to handle mental health and substance misuse? We describe this as care in community, by community, and for community, and it gives people the ability to help those around them in the moment that those people need help the most. But most of us don't know what to say or what to do. We recognize the signs, the symptoms, but our actions are often to tell the person that they need to find someone else that can help, or even worse and more egregiously, call 911 or send them into the emergency department, places that are ill-equipped to help people in that moment. And while there are times where this is appropriate, there are so many people who languish in this pattern because we simply don't know what to say to help them. Next slide, please. So what would happen if we trained up our community to help each other? So we took the community-initiated care concept, we branded it differently as Strengthen Us, and this effort is grounded in this growing field of social neuroscience, psychological interventions, and understanding of how evolution has helped shape human interactions and challenges us to tap into this natural empathy, these natural strengths that we all possess as a way to heal one another. We all have the strength to support one another, and we all need help from time to time. And in doing so, we can strengthen our communities. And you can learn more looking at the QR code in here. It is an activity that I think we're really excited about to see where it goes. Next slide, please. We are actively working in Strengthen Us to create a free and simple way to learn how to help. On a continuum of care, each of us are often the first responders and can help with these one-time interactions that can change a person's trajectory, that can save a life, that can give hope. Right now, we have a very simple method on the website that's a start. It's 8 things that can help encourage people to begin to take ownership over these pernicious problems that are seemingly in front of us daily. Our vision is to work with communities, to build off the science and co-create a training that anyone anywhere can use, from barbers to baristas. There are people in our communities that have trusted relationships with those in need. Why not use those to help? Next slide, please. Second, I think we need to use the immediate opportunities in front of us to build out a better system. And in this case, I think we need to leverage 988. Next slide, please. If you're not familiar with 988, hang on tight because this thing goes live in 2 days. Today, there are essentially 2 avenues for a person experiencing a mental health crisis. It's go to an emergency department or call 911. And as I mentioned already, both of these are fraught with challenges and rarely end with a successful intervention where the person receives the care that they need. Data consistently show that people, especially children, wait too long in emergency departments, days or even weeks, for a bed to become available. We must have a better response to crisis, and 998 can become that if we let it, plan on it, and fund it properly. Next slide, please. If implemented correctly, 988 has the potential to revolutionize how we approach mental health and substance misuse and suicide prevention. However, we can't make the progress we want unless we begin to focus on building a broader continuum of care designed to not only effectively address those at the peak of a mental health emergency, but also provide the resources necessary to support crisis prevention. I call it the Trojan horse for mental health reform because it does require us to break our narrow thinking about who is responsible for mental health, how we pay for it, and ways we can get more meaningfully prevention in crisis in the first place. Next slide, please. Here are 3 big things that I think 988 promises to offer. You can see here on this slide. This all requires, though, a functioning system to make work and the resources. Next slide, please. We must be thinking a bit more strategically about how best to approach the continuum of care for mental health so that people are not left with only the most minimal of services. This continuum you see here on the left must include prevention as well as robust standards ensuring the quality and outcomes are achieved. The graphic comes from the CEO Alliance and highlights some of the elements necessary to get us to a system that we need for mental health crisis response. The page on the right, which will be in the Washington Post this Saturday, is alerting the public of what new resources now out there. And I would be remiss to say that while there has been robust one-time federal funding, thank you, this is great, we still need longer-term sustainable funding to support these communities. This is both a state and a federal issue. This could be a useful transition in how we think about mental health crisis and suicide prevention. And an ideal scenario is that people who are in crisis will receive the type of care that they need from the most qualified person responsible for that support. This could help countless if we done right. Next slide, please. Finally, and just ever so briefly, I want to challenge us to rethink about our structures. I'm a systems guy and I think about structures every day. Many of these, each of you have inherited from previous leaders or previous generations. It doesn't make them right, it just makes them what's right in front of us. Next slide, please. So when you back away and look at the data and you talk to people and even consider your own experience, rarely do people who have a mental health or substance misuse problem just show up in a mental health center. More likely, they present in primary care, talk to a friend, share with a teacher or other trusted person in the community. Why don't we put mental health where people are? This slide shows examples of the places that we should be thinking of putting mental health, but yet we're not there. Next slide, please. From libraries to our jails and prisons, any policy that limits where a person can get access to mental health or substance use disorder treatment may need to be a policy that's revisited. We know now more than ever before about treatment. What we have not figured out yet is how to change our structures, our systems, from training delivery to financing and everything in between to allow for people to have more of an integrated and seamless experience accessing help. Next slide, please. And we have to think broadly about the problems, not to paint ourselves into a corner myopically or just focus on one piece. There is no one solution that will work here. Substance misuse and addiction can happen to anyone. Mental health is foundational to who we are. We must embrace these truths. Next slide, please. And we must make this our goal. We must strive to do everything we can to make it easier for people and to be more integrated. Next slide, please. But are we bold enough to embrace a vision where mental health is foundational, to bring mental health out of the shadows, to see the pain that our nation is experiencing is beyond just tissues and nerves, see the trauma that's so pervasive and do something proactively and responsively about it. Look deeper into social connections and belonging and work to heal as a nation. I think we must. I think this is on our watch. This policy agenda requires all of us to see mental health and substance use disorders as cross-cutting, not left just to one agency or one leader, but for all leaders and all agencies. Each aspect of government would benefit from having mental health or substance use experts involved in planning and the development of what's to come, from housing to transportation to more obvious care delivery. We have to think differently if we want to see these trends begin to go in a different direction. Last slide. I'm ready to be the leader for this moment. I know many of you are too. So let's be courageous and bold with what we push for. Let's take risk and let's see what we can impact in the time that we have here to help others. I think that we could set us on a new path for generations to come. It is now my great pleasure to turn it to my friend and colleague, Dr. Arthur Evans. Arthur?
Thank you, Ben. And thanks everyone for joining us. Actually, Drs. Miller and Garcia did a great job in setting me up here for what I wanted to talk about. And actually, as they were talking, I started eliminating things that I was going to say because they did such a good job of covering those things. So what I want to really focus on is something that Ben really highlighted during his presentation when he talked about how we think about substance use and addressing substance use and mental health conditions. So next slide. So I want to talk about, in particular, a framework using a population health framework for how we approach these issues. I think it's essential that we shift the way we think about these issues, because the one thing that I do know, and I was in public policy for 20 years before I joined the American Psychological Association, the one thing that I do know is that if we do the same things, we are guaranteed to get the same results. And so we're going to have to shift and expand the way we think. And I believe that a population health approach is the best way for us to do that. And I think the foundation that Ben just laid, I think reinforces that. Next slide. So where I want to start is with just a little bit of context. One of the things that we know is that there are a lot of different things that drive our mental health status. We know from research and from surveys that have been taken over the last several years that things like the war in Ukraine, inflation, gun violence, that all of these things and the pandemic, of course, have had a tremendous impact on the mental health of the nation. And in fact, not just in the United States, but literally around the world. I was talking to colleagues recently from Europe and from South America and from Africa and Asia. They're seeing the same things that we're seeing in the United States, which is this exacerbation of mental health challenges. And the thing that we know and has been referenced already is that we had a challenge before the pandemic, and now with the pandemic, that problem has gotten worse. Next slide. So if you look at a whole host of things, and I won't cover all of these because I think Dr. Garcia did a great job of sort of laying out the data and some of the problems, but if you look at a whole host of things, from what's happening to our children, to the increases in substance use, to the increases in people experiencing symptoms in the population, to issues like the economy that we know are an additional stressor, that if you look at all of these things collectively, we know that we have a significant problem. That problem has gotten worse during the pandemic. And if you go to the next slide, one of the conclusions that we have to understand is we cannot treat our way out of this. And I'm saying that as a psychologist, as someone who spent their entire career attempting to get more treatment services for people, trying to get more people into treatment services. Treatment services are important, but if that's the only thing that we do, there is no way that we can get a handle on the problem, the magnitude of the problem that we have. And many of the things that you heard Dr. Miller talk about in terms of getting upstream, using approaches outside of our traditional treatment system are going to be essential. That is the big takeaway, I think, from I think what all of us are going to be talking about, which is how do we go beyond what we have traditionally done and think differently and more expansively about the ways that we help people. Next slide. So let me start with why I think this problem is so intractable. It's not intractable. Why we have not made the progress that we should have made at this point. Part of it is the way we think about and conceptualize how we help people. what you see here is a pyramid of a depiction of the population. If you add up those numbers, it adds up to 100%. About 25% of the population will have a diagnosable mental health condition, 75% will not. The way our healthcare system works is that if you're above that line, in the 25%, you have a diagnosis and you can have access to healthcare services. If you're below that line, we pretty much ignore you until you have a diagnosable mental health condition. There are a lot of problems with this way of thinking about health and healthcare, but let me just point out a few of them. One of them is that many of the people who are in the 75% today will migrate and be in the 25% at some other point, but because we ignore people until they are at some level, and often at a crisis level, we've missed the opportunity for prevention and for early intervention. If you look at most public mental health systems around the country, they spend about 1 to 2% on services outside of treatment. So they're spending 1 to 2%, maybe 3% of their budget on things like prevention, early intervention. Most of our resources are not only for people who have a diagnosis, but at the very top of the pyramid where people are in crisis. So first problem we have is that we have a very reactive, after the fact approach that requires people almost to be in crisis before we help them. So first problem is we're focusing on only a small part of the population and often in a reactive way. Next slide. The second problem is what we are focused on. So the first problem is who we're focused on, only people after they are in crisis. The second problem is what do we focus on? Most of our resources, if you look at this pie chart of what drives our health status, one of the things that should really pop out to all of us is healthcare is only about 10%. So most of our health is determined by things outside of the healthcare system, yet we will spend this year probably somewhere close to 4 trillion with a T dollars on healthcare. The last number was about $3.5 trillion, but we've inched up because of the pandemic. So we're spending a tremendous amount of money on something that counts for 10% of the variance in our health status. And we often ignore all of these other factors that have a much bigger influence on our health status, including our mental health status. And so the second question is, how do we start thinking about those things outside of healthcare that can make a big impact on our health status? Next slide. Often those things are referred to as social determinants. We've talked about them, housing, those kinds, housing, food insecurity, income, all of those things are very important. The issue isn't that all of a sudden we're going to abandon what we've done and focus only on these issues. The issue is, I think, twofold. One is, how do we partner with, in the mental health world, the behavioral health world, with agencies, entities that can provide these other services so that we can provide the kind of braided services that people need in order to be successful. But the other is, how do we conceptualize, as we're thinking about how we work with people, these issues and how they can be folded into our overall approaches. Next slide. So I want to, this leads us to, I believe, really rethinking this idea of only focusing on people after they are in crisis or after they have a diagnosis, and thinking about how do we not only address those individuals, but how do we get upstream and work with and intervene with people much earlier. If you Google the term population health, and I encourage all of you to do that, you will get literally hundreds of references. And people talk about it in many different ways. So let me talk about how I think about it. One, if you took that pyramid of the population that I showed earlier and you divided it into 3 different sections, people who have a diagnosis, people who are at risk, and then people who are healthy. Here's what our public policy would look like. We would be really focused for people at the top part of the pyramid on providing effective and efficient clinical care. For people who are in that middle part, they don't quite meet that diagnostic criteria, we wouldn't wait until they're in crisis before we help them. What we would be looking at are there ways to reduce the risk? And if we can't reduce the risk, intervene early. Another important population is in that group are people in the field we would call subclinical. That means they are experiencing problems. They just haven't risen to the point where they might qualify for treatment services, but they still can still benefit. We saw, for example, during the pandemic, a great example are people in the healthcare arena who were, under a tremendous amount of stress, experiencing a lot of psychological distress. And the issue is, should we wait until those people have more significant problems, or should we be intervening at that point? And then for people at the bottom part of the pyramid who are healthy, how do we keep people healthy? We do that for physical health. We talk about diet and exercise because we know that doing those things will prevent a lot of more significant healthcare issues. We actually know a lot about correlates of good psychological health. And the question is, how do we incorporate those into our overall approach so that we have a more literate population? People are taking more control over their own health, mental health status, their behavioral health status, and doing things that prevent them from having deeper end problems. So if you go to the next slide, what I want to do now is just give you some quick examples at each level of the pyramid, and then I'll make some summary statements. So an example of providing effective, efficient clinical care, one of the best examples during the pandemic has been telehealth. Enormously important because we're reaching people that we have historically not reached. It's going to be important for us to continue to do that, particularly in frontier states and rural parts of our country, but even in urban parts of our nation, because often people in those urban centers don't have methods to get to the services that they need. So this is a strategy that is important across the whole continuum of our nation. But this also includes at the top part of the pyramid things like focusing on our workforce, ensuring that we're using evidence-based practices, reducing disparities in access, because all of those things help us to have much more effective and efficient clinical care. Next slide. In the middle part of the pyramid, we're really talking about reducing risk. So for people in the healthcare arena during the pandemic, one of the things that we tried to do is provide them with scientifically based strategies to reduce their stress level as a means of reducing the risk that they would develop deeper in mental health or behavioral health problems. But we can do that in other ways, like looking at the issue of trauma, using data to identify groups or individuals who are having challenges, doing screening to identify people who are at greater risk, and then intervening, again, not waiting for people to have deeper end problems. Next slide. And then how do we help people stay healthy? One of the best examples of that is psychologically safe and supportive schools. Really important strategy of creating school environments that are supportive of our children's psychological health, helping them with life skills, for example, as a way of inoculating them against the kind of stressors that might lead to mental health challenges. The idea here is how do we improve the mental health literacy of the population, but also how do we create environments that are psychologically supportive? All of us have probably experienced at some point in our lives environments that are psychologically toxic, that lead to poor mental health outcomes for us. We can also be intentional about creating environments that create support for people. And then last slide, let me just conclude by saying it's really going to be important for us to make a conceptual shift from thinking only about treating people after the fact and really thinking about a whole population approach that reduces risk, that keeps people healthy, and it treats people once they have very significant problems. So with that, I'm going to turn it over to my friend, colleague, Schroeder Stribling.
Well, thank you very much. Thanks, Dr. Evans. And first of all, I also want to thank you, Dr. Gracia, and Trust for America's Health and Wellbeing Trust for this important research and reporting, and for the opportunity to be a part of the discussion today. And I want to note that I'm in an even worse position than you, my friend Arthur, because you and Ben and Nadine have already covered so much important ground. And I appreciate that the three of you have already given us a wonderful basis both for understanding and for action. And I would especially emphasize the common points that we would make about the opportunity now to think differently and think more expansively, as Dr. Evans put it. And also the points made about a population-based approach, focus on social determinants, and the opportunity, as Ben discussed, to strengthen us, as in all of us. I very much appreciated those. So I will try not to repeat those contributions, but look instead to offer some additional points from our work at Mental Health America. Next slide, please. As quick background for my remarks, Mental Health America is a national organization with 143 community-based affiliates around the country who are delivering direct services and have been rapidly innovating over the last couple of years to meet the needs, the urgent needs of their local communities. At the National Office of Mental Health America, we provide federal, state, and local policy advocacy in support of our affiliates, and with them, public education efforts and research to support our affiliates in the broader field. And also since 2014, the National Office has been operating a free anonymous online screening program, which is aimed at promoting prevention, early intervention, early identification, and early intervention. And our screening program is currently seeing about 15,000 individuals each day. And during the pandemic, this was an especially important tool in giving us real-time information about the mental health of the population, and especially youth, who are the most frequent users of the program. So today I will discuss some of the data we've been watching from the screening program. I think you'll find that it supports all of the input of my colleagues here. And most importantly, I think points the way to where our greatest opportunities for leverage are, and where we can get in with that prevention, early identification opportunity. The vast majority of those who use our online screening program have never sought mental health help before. So that's interesting in and of itself. So we can see where the pain points are. We can see where the help seeking is happening. Certainly for youth, this is often online first, and we can see the ages and stages of individual distress and where we can focus our efforts and innovations. So I'll discuss some of our screening data, talk about our premise for prevention and early intervention, including our focus on social determinants. I'll touch on our policy priorities, which follows from this research of ours and that of others like Tifa here. And lastly, I'll discuss some of the community-based work of our affiliates, and then highlight a pilot innovation program, which we're now launching, which aims to rapidly engage individuals who take our substance use screen and connect them with both digital and in-person peer-led supports. Next slide, please. Okay, this information is taken from those who take our online screen for depression. And you can see that we note suicidal ideation is highest amongst youth. You can see the ages of here, and you can see that the percentage of screeners who are reporting suicidal ideation. So ages 11 to 17, certainly at the highest. However, I would note in the blue box that as we were discussing this the other day, our data guru quickly looked up what was true for June of 2020 2022. And this is especially distressing point here that the age group with the highest reported rates of frequent suicidal ideation were 8 to 13-year-olds. Next slide, please. Here you can see the change over the past 2 years about who are experiencing self-harm thoughts. There are increases across the board in thoughts of self-harm during these years. However, certain populations are experiencing this as notable in some more than others. And the largest increases for screeners during these years were those who identify as Black and Native American. You can also see that there's pretty high percentage for those who identify as multiracial or other. Next slide, please. So for those who take our substance use screen, this is our 2021 data, and this is all ages. When you look at who the populations are who appear most at risk, we've got students at the highest, and we're going to assume that most of those are youth, though some may not be, obviously. LGBTQ folks come out very high on suicidal ideation. I know a lot of us are tracking this particular point as well. Also notable is those who live with chronic pain. So a lot of folks note comorbid conditions, other health conditions, and those who identify as trauma survivors. When they discuss the type of substances used, you'll note alcohol, marijuana, and tobacco come out highest, of course, but really important, I think, is what's highlighted in blue is that a very high percentage, almost close to the highest, say that they're using more than one. So the lower percentages for stimulants, cocaine, opioids, et cetera, I think we can assume that those might be in combination with the leaders there of alcohol, marijuana, and tobacco. Also notable is the percentage who report other self-harm behavior that's not substance use, but perhaps things like cutting, et cetera. Thanks. One of the things that we like to emphasize is that these early risk factors, getting in early makes a difference. And so knowing where we've got these greatest points of leverage for intervention is really important. We know that ACEs have a lifetime effect, that the early life trauma and ACEs more than double the odds of developing later mental health conditions. These do include depression, bipolar disorder, and schizophrenia. We know that children and youth who are living in poverty are 70% more likely to have a mental health condition. Adolescent mental health problems almost double the odds of being unemployed in adulthood. And of course, there's increased risk for victimization for people with mental health and substance use conditions. So early risk factors are extremely important. The more upstream we can get, the better. Next slide. In our policy focus very much would reflect what my colleagues have said here as well. So incorporating prevention across all mental health and substance use programs. And I think this goes to Dr. Evans' point about that lower half of his triangle is how do we help people stay healthy, and how do we focus on mental health literacy and resilience skills that support that, and ensuring that we take a public health approach or a population-based approach to all of our mental health and substance use programs, access to integrated care, primary care, and mental health care. And we would emphasize starting at the very earliest of ages, including with maternal health. Meeting young people where they are. This might be online, in school, after school, in the community, at Head Starts, at Boys and Girls Clubs, et cetera. Again, this follows the comments of my colleagues about getting to people where they are in the community. Also, the effective integration of peers at all levels, youth peers, adult peers, making sure that they are a part of the workforce, making sure that there is fair pay for peers. And then I would expand that point also back to Ben's point about the notion of strengthen us in terms of equipping everyone to be able to understand their own and others' mental health challenges and feel empowered and abled to respond to them in some way. Support for new technologies, digital therapeutics. We have a screening to supports program that was launched with our screening program in 2014, which was an early prototype for digital therapeutics that provides both support for people who come to take a screen, a free anonymous screen, gives them some online information that they can self-navigate through, but it also helps them navigate to in-person supports where they need it. So again, meeting people where they are and following them from the earliest point of identification. And then an accountability for the individual's experience of care. One of the things that we're pushing on right now is having the patient experience be measured. So for those people who are at the top part of Arthur's triangle, who perhaps need hospital or emergency-based care, we know that hospitals measure patient experience for all patients who enter the hospital, except for those who come to use psychiatric services. So we would like to see more accountability in that. And then involving individuals in guiding their own care and advancing their own community solutions. Next slide, please. Additionally, in our policy focus, we're very interested in the administration's push for health equity plans. And we would like to see these health equity plans implemented and also to push them a bit farther to address disparities and to measure the outcomes that come from them. So not just indicating that you have a health equity plan, but then measuring what it does when it's implemented, and asking that health equity plans have an explicit focus on social determinants of mental health. So healthcare systems, we think, can use their procurement practices, hiring practices, investing and advocacy to address social determinants and improve outcomes for BIPOC individuals and other at-risk communities. Healthcare systems can use their hiring practices again to hire peers, ensure that they're paying a living wage, and invest in some community assets such as the development of affordable housing. And we have seen some healthcare systems across the US already taking on these types of activities. And as Dr. Gracia said at the beginning, I've been working before being at MHA in homelessness work, and it was very interested to watch as a number of hospitals started to develop affordable housing, recognizing that it was a cost-effective solution to solve one of their problems, which was the overuse of the high utilization of their services, because folks did not have adequate housing in order to maintain their health and well-being outside of the hospital. Next slide, please. Our affiliates across the country are working in schools, and they're working online, providing awareness, public education, and trying very much to normalize help seeking, working to prevent ACEs, using family support programs, trauma information, and mental health literacy, focusing on lived experience, inclusion, and leadership, peer support with a special focus on youth peer programs, person-centered wraparound programs, and drop-in centers. I was just visiting one of our affiliates in Oklahoma who has some really innovative, fascinating programs that focus on social determinants for people who are both homeless and experiencing a mental health condition. And I spent a day with their outreach team and also with their alternative to panhandling program, where they bring folks from who are panhandling to work in park cleanup, and they pay them $65 for the day. And during lunch, which is provided, they are also able to speak with counselors and vocational support folks and others. So rapidly innovating out there to address these social determinants. Also integrated supports, housing, employment, social supports, and public education and health-focused campaigns. Next slide. Lastly, I wanted to mention one innovation that our pilot program that we're launching that is going to work with our research department and our screening to supports program and a new funder and a couple of academic institutions that we're working with to help individuals bridge their an initial need for substance use support with either online or in-person peer support. So we're using our screening to supports platform to understand how it is that people engage with supports, what it is that they're looking for when they come online, what helps that is self-guided, what helps that is peer guided, when do people need to make that bridge to an in-person intervention, and how can we best make that a seamless continuum. So we're going to test those content and strategies, working with 5 of our affiliates in different parts of the country and focus on substance use, depression, and anxiety. Then we'll test that and continue to refine. So that is the conclusion of my remarks. And again, I want to second the remarks made by my colleagues, and thank you again for the opportunity to participate.
Wonderful. Many thanks to all of our wonderful panelists, just the important information that you shared, but not only presenting what the challenge is, really what we need to do with regards to solutions and recommendations moving forward. And so we're concluding that this part of the presentations and moving now into our discussion. And I want to encourage, again, we've seen some questions coming in from the audience, which is wonderful. Please do continue to put your questions in the Q&A panel, and we'll get to as many of those questions as possible. And I'm also going to be joined by my colleague, Brandon Revis, who's our Senior Government Relations Manager at Trust for America's Health, who's going to help moderate the Q&A that is coming from our audience. So let me begin, with some questions to each of our panelists, really on a focus that has been, and Shorter, you actually used a good word, the word distressing. Some of these findings in particular, where an area where we've all touched upon is our youth, and seeing in particular the crisis in our youth as it relates to mental health, as it relates to suicide, and certainly understanding that all of these events, Dr. Evans, you spoke to many of them that are happening in our nation, and the impact that is having on our youth and their mental health and well-being. And that predates even the pandemic, but in the course of the pandemic, we know that there are even greater stressors that have taken place, and even some of the more recent events that we've seen in schools that have truly been distressing. I'd like for us to talk a little bit more and delve in a little more to some of the recommendations and areas that you each focused in on as it relates to what we can be doing, for example, in the schools, because that's such an important setting when we talk about especially prevention and for our youth. And Dr. Evans, if we can start with you in particular, is really identifying, and you've touched upon this importance with regards to the education that can be done in schools, but also the services that can be done in schools. How can we really think about these schools as this nexus of support and services as it relates to mental health and well-being for our youth? And specifically, what should administrators be doing, and what are the policy recommendations, therefore, that are needed to advance these types of reforms in our schools to help support our students' mental health and well-being?
Sure. When I was a mental health commissioner, I worked very closely with the superintendent of schools. And essentially what we did was we replicated that pyramid that I talked about earlier, really having a comprehensive approach to how the district was thinking about schools and thinking about mental health and being integrated in schools. And so I think that the strategies have to be at all levels. One is that, school climate programs are very effective. We ought to be making significant investments in school climate programs where everyone in the school is getting exposed to what it takes to have a psychologically healthy school environment. The teachers, the administrators, obviously the students. But also then, at the middle part of the pyramid, we know that there are children in the schools that are at greater risk. And again, often we wait until those kids are in some kind of crisis. There are lots of different things we could be doing, like screening students to identify those kids that may be having suicidal ideation or maybe having other kinds of challenges, so that we can intervene much earlier. One of the places that I was a commissioner was in an urban setting. And often in those settings, you have children that are being exposed to trauma in their communities, could be gun violence, those kinds of things. Those children don't leave those things in their communities and then come into schools. They bring those things into the schools. And I think we could do a much better job of understanding that, identifying those children who have been exposed, and you don't have to have one-on-one interventions. These could be group interventions that you can do. So a lot of these interventions can be done quite efficiently. But then we also need to make sure that all schools have a way of identifying those and providing services for those children who are at the top part of the pyramid, or who are experiencing significant problems. And in the case of the system that I work with, we actually had school-based behavioral health services, clinicians in the schools, children receiving those services in the schools. And that's really important because in some instances, children who are having these problems are sometimes coming from families that have a hard time making it to a community-based provider. And so thinking about that pyramid and replicating that in schools, I think is a really important strategy for ensuring that you have a comprehensive approach. One last thing that I would say, which is really important, that is the issue of leadership. You have to have people certainly at the superintendent's level, but all the way down, principals, teachers, who understand these issues, who understand how they play out, and have a commitment to working on these issues. Every person in the school district should know that one of the biggest predictors of whether children will do well in school is whether or not they have a social and emotional problem. That's what the data say. So if you're an educator and you care about that issue, and care about children being successful, then you have to care about ensuring that they are psychologically well, that they are that their social and emotional needs are addressed, and that's going to take a commitment at all levels within the school district.
Thank you, Dr. Evans. Dr. Mill looked like you wanted to jump in. Please do.
Well, yeah. Arthur just said it so well. I have to make a couple of comments in response to that because it very well said, and I just want to build off and say two things. I mean, one, I think we have to acknowledge that even in the last week, within major legislation that's been passed by this Congress on the Bipartisan Safer Communities Act, there is a substantial amount of resources in there, over $1 billion for youth mental health. And much of that is directed towards schools. So to Arthur's point, and to this influx of cash that's about to hit the schools, there really needs to be a very clear articulation of what should be done, what best practices are. What are the ways that schools can pick up the evidence and immediately put it into practice? I'm a former school teacher. I taught high school for a couple of years, special ed. And I have to tell you, it is one of the most demanding jobs I have ever had in my life. And to not have resources that can help those kids that are in the most significant need is just a shame. Well, we're about to get them. And it's going to be a very important time for us to make sure that the schools actually implement the things that are most effective. That's number one. Number two, my good friends at Inseparable have done an amazing job with their Hopeful Futures campaign that has laid out how states are doing as it relates to the issues of school mental health. I mean, there is no more fertile ground to meet people where they are than in schools. And it is a place that I think that we can be doing so much more work, yet there's very few resources and clinicians to show up in those places. Well, the resources are on their way. We got to make sure that the clinicians are. And so Hopeful Futures put out a report card that showed how all states have fared with the number of clinicians that they have on site. It's a good talking point that allows you to engage with policymakers on some of the facts of what's needed. And last point I'll make, and then I'll be quiet. I said two, but I'm going to go to three. I do think if you look at the literature that youth are much more comfortable receiving help from each other than they are, older adults, clinicians, and the like. And I think that there's something very powerful in there. And Schroeder alluded to some of this in the data, that our youth have significant needs right now. Adolescence is a hard time, always has been. But now with social media and some of the influx of additional stressors, including the last couple of years of COVID, they really do need to have the skills necessary to help them turn to each other and show those supports. And schools can play a role in giving them those skills. Unfortunately, I think what we're seeing right now is some ideological and political fighting that has made it a little bit harder for us to use some of the discussion points that we've had in the past around bringing mental health into schools. But it is a moment, and I don't see these very often. I told somebody this morning, this is one of those propitious moments that we don't get very often, to really focus in on our youth, to meet them where they are and to equip them with the skills necessary to help each other, because that's going to have a generational impact, because they are going to be adults one day. And those adults are going to want to pass on those skills to their next generation. They're also going to want to be able to be there for the adults in their life. So I appreciate the question, and it's a timely topic.
Can I add one other point
Please,
that I
go
think is
ahead.
really important, and Ben's comments reminded me of this. I talked a lot about what services we need to put into the schools. We also need to think about how do we help administrators and parents around these issues. Ben mentioned that there is a lot of money that's going to be going into those schools. The question is, okay, do administrators know how to use that money effectively? We have to make investments in the people who are running these systems, helping to educate them, helping to inform them about what the research says about what effective strategies are. And often we are so quick to, or we want to get to the program without understanding that programs operate within an administrative administrative structure and system. We have to make sure that people running those systems know what the best practices are. So I think that that's an area where we have to make investments, and we absolutely have to make investments with parents, because children's mental health, one of the strongest predictors of how our children will do is how parents do. And so if we really want to improve children's mental health, we have to not only have services for them, but we also have to have the supports for parents, because they are very influential in terms of how children are going to do in terms of their mental health status.
Dr. Miller, I'm going to throw something over to Schroeder based on what both Dr. Miller and Dr. Evans were alluding to. I mean, both of you speaking to the fact that the experiences, the social determinants don't stop at the door of walking into a school, nor when you leave the school for our youth. And importantly, how we need to think about these investments that are going to the schools. Schroeder, you in particular also highlighted the impacts we're seeing on specific groups of youth, whether it's LGBTQ youth or youth of color. And so how do we think about that, specifically tailoring the types and ways in which we're reaching students that we know are feeling even more disconnected, feeling more isolated, to assure that these types of investments, and that they're not only one-time investments, but that they're sustained? How do we assure that we're really providing equitable access to those types of services? And what message would you then give to policymakers about thinking about this in the long term?
Well, that's a great question. Thank you. And I appreciate both Arthur and Ben's contributions on it. And what that makes me think about when you ask that question is really a bigger framing issue, which is, in my mind, stigma and bias are really in our way still of having a true public health perspective, and that we still need to zero in on these issues of stigma, bias, and discrimination, and that if we dealt with those, that it would be obvious that we need to take a public health perspective to this, and that we need to prioritize prevention. So, in my mind, I have an imagination for the fact that, when it was obvious that we needed to take a public health approach, say, on childhood diabetes and preventing that, and every child knows now that they should eat their fruits and veggies. Wouldn't it be wonderful also if we had every child who knew the self-regulation skills like box breathing, et cetera, and that we had qualified people, whether it's the pediatrician, whether it's the parent, whether it's the teacher, who all understood that these are ways to optimize our resiliency amongst everybody. But the other thing that it makes me think about is that in addition to mental health literacy, which I think we've all talked about the importance of, I think about this in a certain way too, of that we need everyone to have, and this I think is part of the strength in us idea that Ben was talking about, that we need to have social conditions literacy, that everyone should be empowered to understand the effect of the social conditions that they're in. So for an LGBTQ youth, as I was once upon a time, to understand what the social factors are that are influencing your mental health and where you might get help and what things might be affecting your mental health and where to find specific supports, I think is particularly important. So I think it's a way to improve the impetus for individual self-advocacy as well as community self-advocacy around these social conditions issues. So those are the things that I would press on.
Absolutely. Thank you all for those responses. And I'm going to ask one more question of Dr. Miller, and then we'll turn to Brandon to take some audience Q&A. And Dr. Miller, we use this first framing around the schools themselves, and could expand that to thinking broadly about youth serving programs. And you spoke in particular about community-based services and bringing services to the community where they are, and thinking about how we think about these systems. Can you talk a little more about what the barriers may be with regards to kind of transforming our models of thinking with regards to actually bringing services more into the community, and what opportunities now exist either through the legislation you just referred to or other types of policies that we can advance in this arena?
Well, that's not an easy question, Nadine. It's complicated because I think, and I alluded to this in my opening comments, that we are trying to solve major systemic problems on faulty foundations. That the history of mental health in this country and how we approached so many of these issues is that we continue to have this mindset that mental health should be separate. And we continue to have this mindset that we can treat health as like one disease at a time. And that stuff just doesn't work. So when you talk about these broader, more inclusive and integrated approaches to care, it's almost like we have to go back, reverse engineer from where we want to go and look at all the things that stand in the way. In the literature, in the policy literature especially, they talk about this as, deprescribing policy. There are policies that still stand in the way, and Arthur can speak to this better than anybody, that we have to undo. Putting more policies on top of those broken policies doesn't necessarily solve the foundational structural problems that are inhibiting us from being able to move forward. So I think it's a broader framing comment to your question, Nadine, but I actually think it is something that many people don't want to take on. So the second piece to that is, okay, once we recognize that the structures are inherently against us, what do we do? Well, I think it begins by recognizing all the places that people are, and we can do this with our data. I've done this in several states. You begin to follow all the places that people show up with mental health needs. And what you realize in doing that, and this is a powerful case to make for policymakers, for those of you that are looking to do this, is it shows that rarely are the clinics that we've created and put the most money into where we see the substantial amount of the population showing up. Now, I am not trying to knock any particular profession or clinic space here. Everybody's important here. But we have created this almost like single point of entry for mental health and substance misuse that most people don't walk through. So diversifying and democratizing those programs and those approaches allows us to better go to those data points that we know we'll have, which is where people are. So I think we have to use the data to help make that compelling point. And then three, and this goes to something Schroeder says, we have to change the culture. People expect fragmented care. They expect that they actually have still these biases around what mental health is and what mental illness is based on who they might have seen on the news or on the street. They don't necessarily have a full working understanding based on their own experience. And we have to change that. Mental health is all of us. This is foundational to who we are. I said that earlier. But we have to change the culture so that people begin to expect a different type of approach to mental health and substance misuse. Look at some of the programs that are being done right now around harm reduction. You would think that while these are extremely efficacious programs that save lives, you would think that we are trying to do some of the most provocative, not tested, untested interventions out there based on some of what you could read in the news. That's just simply a cultural change and mindset shift that has to occur. So all three of those things are very complicated, and I'm not giving you a straight answer because there is no straight answer. But I do think that this is why I'm encouraged in this moment. 10 years ago, people like us on this panel, we used to try and convince people to pay attention to mental health. Like literally, we would say, can you say the words, please? Now what we're doing is that everyone's paying attention to it, and we get to have the real meaningful conversation about that deeper structural change that's necessary, the cultural change that's inherent within that. That to me is progress. So I'm going to say, while it's complicated, we are indeed moving in a direction that I think is positive.
Can I jump in there?
Dr. Evans, I'm gonna pause you
Okay.
actually, just so we can start moving into
Sure.
into some audience questions, and it may actually
Okay.
tie in, I'm sure, to some of the points that you will make. So Brandon, let's take one of our audience questions now.
Thank you, Dr. Gracia. The first question is directed to all panelists, and it asks, what policies and reforms at the federal level could help address the trends the panelists have highlighted, and what advocacy is needed to make these changes possible?
Dr. Evans, would you like to kick us off?
Well, I think that a few things could help us. One is, I think we, first of all, have to recognize that we have to have a strategy, a national strategy around prevention, early intervention. Right now, our focus is almost singularly on treating illness as opposed to addressing mental health and behavioral health issues. And to me, those are different. Addressing these issues can happen in multiple ways, treatment being one of them. So that's the first thing. And every opportunity I get to talk to policymakers, people in Congress, that's, I have that mantra. And I think more of us need to talk about that. Secondly, I think that what policymakers need are more flexible funding. The problem that most administrators of mental health systems have is that their funding is categorical. It's locked in. It's for a specific thing. These issues are complex, and as Ben was talking about, I so love that question about how do we get services into the places where people actually go. It's one of the things in my last job as mental health commissioner we spent a lot of time on. But in order to do that, you need flexible funding. If your funding says you can only use these dollars for this, then I can't be creative and have a partnership with the library, for example. You say, well, why are you putting services, mental health services in the library? Well, because in most places, if you are homeless, that's one of the few places that you can go in communities, and often those people have behavioral health conditions. So if you're trying to get people where they are, you got to figure out where are the places that people naturally go and then embed people there. In my last position, we had mental health people in jails, we had them in hospitals, we had them in schools, we had partnerships with the fire department, even with licensing and inspection. Why licensing and inspection? Because often people who hoard get identified by licensing and inspection. They don't know what to do with those folks. And so we really have to think about the places that people are going to pop up, embed either mental health professionals there, or to partner with those organizations so that those organizations have a strategy. That's going to require flexible resources that administrators can use to get services or to create new services and strategies in those areas.
Can I build on Arthur's point there?
Please.
I so agree that one of the things we need to do from a policy perspective is really hit hard on the notion of prevention. And one of the things that I think is difficult right now is being persuasive about why we would focus on prevention, about spending our money now on prevention when there's so much urgent need and crisis. So when there are so many people who are at the top of that pyramid, or we've got so much focus on the top of the pyramid that Dr. Evans shared with us, how can we help people understand why it's important to focus on those other layers, and why we invest in prevention now to prevent more people from flowing upward into the top of that pyramid. And to Arthur's other point about flexible funding, both flexibility and perhaps also incentive in funding.
Mm-hmm.
So it's nice to be able to use your dollars flexibly, but also it's good to have set aside specifically for prevention. That might be part of incentivizing what we do to help get that investment underway now.
Absolutely. And I would add to that, excellent points, and it's notable how we're talking about the need for flexibility of funding, which is also something that we speak to around core public health services, and the need for that flexibility and the ability, for example, of public health to also be interfacing and working in this space of mental health and substance use, would be really also addressing these underlying structural drivers of poor health. And so recognizing that this is multi-sectoral, as been indicated, it is complex, but we do need to be addressing root issues of poverty, of discrimination, of lack of access to affordable housing, of food insecurity, that are causing these financial hardships and stressors that for some then without those resources may turn to substances to be able to cope, may feel isolated. That until we address those root causes and for example, have investments in social determinants of health to provide flexible funding, for example, CDC's social determinants of health program, and increasing investments there that will then create that type of infrastructure in public health to be able to also partner with other sectors to address those root causes, I think is also a critical opportunity for us as it relates to policymaking.
Agreed, absolutely.
Brandon, do we have another question from the audience?
Our next question is for Dr. Evans, and it asks about the specific impact of the pandemic on children's mental health and what possible reform approaches can help serve vulnerable populations among youth, like children involved in foster care or unhoused youth.
Yeah, another great question. We know that the pandemic has a tremendous impact, and the causes are multiple. We have a lot of children that lost parents, they experienced significant loss, parents or grandparents. Part of it is driven by the missing important milestones. We know that one of the biggest protective factors that we have is social support and social connection. And we cut that off from children at a time when it's really critical. So there are a lot of different factors, and those are just a small list, or obviously a longer list of things that have driven some of the mental health impact. I think that the issue around how do we embed mental health services in some of these other systems, like other child serving systems, is absolutely critical. And we ought to be thinking about that on really every child serving system, because if you go to those systems, you go to the child welfare system, you even go to the recreation department in a local community, they will tell you that one of the biggest challenges that they have, and the top one or two, will be children with mental health or some kind of behavioral health challenges. And that's consistently, and it doesn't matter what the child serving system is, you're going to get the same answer. And so the policy issue is, how do we make sure that those systems are better equipped to deal with children when they show up in those systems? If you're in child welfare, you just have to assume by definition that all those children have experienced some level of trauma, and that you have to be working both at a systems level for that system, but also making sure that you have individual clinicians, professionals in those settings that can address children's mental health needs. It can be done. It's been done in lots of places around the country. And I would say that if you're in a community or if you're in a state that doesn't routinely do that, that's a problem, because you're not meeting the needs of those children.
Excellent. Brandon, do we have another audience question?
Our next question is for Dr. Gracia, and it asks, what changes should policymakers prioritize to engage in upstream prevention, address social determinants of health, to create conditions that promote well-being and resiliency?
Yeah, it's an excellent question. And I think all of us have really been articulating where, it's important to have access to care and services and treatment, but we also have to assure that the community conditions actually promote health and well-being and resilience. And so we have significant opportunity in which policymakers can really be thinking about these investments in social determinants of health, whether it's policies, for example, that look at assuring economic opportunity, livable wages, access to affordable housing, ensuring that communities are well designed with regards to transportation and food security, and ensuring that families have access to healthy and nutritious foods, the design and built environment, as well as looking at community safety. And we've spoken, for example, with regards to exposure to violence and how that in and of itself is an adverse childhood experience, can be a traumatic experience, is how we build these safer communities and assuring that communities have a sense of cohesion and the resources that are needed. But oftentimes, as I believe as Dr. Evans was first indicating, a lot of the funding that comes out of the federal agencies that Congress appropriates, it's very restricted, it's categorical, or it may be specifically focused on a particular disease. And while it's important really to certainly address where we see high rates of specific conditions, it's also important that we have the flexible infrastructure of funding. And so that can be funding, for example, as I noted earlier, into programs such as CDC's Social Determinants of Health program, to really be able to give the public health infrastructure the resources and supports to be able to work across communities, to work across sectors to address these broader community conditions. But we also have to look at these longer standing policies and inequitable systems in education and in housing that also contribute to these poor health outcomes. Schroeder alluded to her work, for example, in homelessness. People don't exist in one bubble. There are many dimensions to a person's character. They're affected by their housing, their ability to access food, to be able to put food on the table for their families, and to know that their kids are going to schools where they're safe and having high quality education. We have to come together truly in a multi-sectoral fashion. And the way in which lawmakers can really address this is assuring that those investments really look at those cross-cutting multi-sectoral factors to health.
Can I just build off of that really quickly? I also think it's inherent that the mental health advocacy community embraces those strategies as foundational to their success. What happens is that many of us get caught on our heels trying to find the next funding for the next program and aren't able to really go bigger and think about these things that you were just laying out. So when we talk about things as basic as like paid medical and family leave, or earned income tax credits, or these policies that don't say quote unquote mental health, it's almost like we need a new bumper sticker in our car here, because like these are the issues that can transform the mental health and well-being of our communities, because they are communal, they're community factors that play a much deeper role. So I'm not trying to criticize here. It's just, I think that we have an opportunity, especially now, to really broaden our approach and our understanding of what we should be advocating for, and to take credit or to give credit when credit is due for those policies that actually allow us to go deeper on approaching a community's mental health, which is through those conditions that you just described so beautifully, Nadine.
Brendan, I think we can take one more lightning round question before we conclude for one of our panelists.
One last question for the panel. What are the special initiatives that can help address issues of treatment and access in rural communities? And what other initiatives can help address the stigma that might surround mental health in these populations?
Maybe let's have one of our panelists take that. So who would like to jump in here to take that question?
I'll take that one. Actually, the American Psychological Association has been focused on rural health. And one of the things that I think is really important is that we talk to rural communities. I spent some time talking to farmers in Wisconsin, for example. And one of the things that they talked about is that the farm community is in crisis. I mean, most of the nation doesn't know that. I remember earlier in my childhood, there was a farm crisis and it was in the news all the time. Well, farmers are experiencing a similar level of crisis, but people don't know that. People don't know that the suicide rate for farmers is much higher than the general population. So I think part of it is legislators, policymakers have to understand that there are some unique needs there, that there is a particular culture. We talk often about cultural competency, and we usually talk about that in the context of communities of color or maybe gender diversity. But the reality is that there is a particular culture within those communities. And I think as we talk about these issues, we have to understand that culture and frame things in a way that is acceptable to that culture. I think that's number one. Number two, I think this is another area where peer strategies are really important when you have other farmers. For example, one of the people we worked with was a psychologist who was also a farmer, right? But you can also have other people who are in the community who are in recovery themselves, who can also be that bridge between people and the services that they need. And then lastly, I think we have to use the other technologies and policy levers that we have, telehealth being one of them, but there are other strategies that we ought to be employing and making sure that we fully fund so that people in those communities and frontier communities, which is a whole nother issue, level of complexity. It's not just further distances, but they have some unique issues in those frontier communities that we also need to be paying attention to and addressing.
Well, as you can see, this is such an important issue and one in which all of our panelists, I certainly want to thank for their expertise and contributions to such an important discussion around the mental health and well-being of our nation. And so please join me in thanking Dr. Ben Miller, Dr. Arthur Evans, and Schroeder Stripling for their excellent information that they've shared, resources that you are seeing coming in through the chat. I'd also like to thank our team at Trust for America's Health that has been providing all the technology and logistical support in hosting this briefing and national webinar, as well as AI Media captioning service for ensuring our accessibility of these proceedings. And to each of you as our participants who participated in this discussion. Clearly there is much more that needs to be done. And as everyone is saying, the urgency and the time for this is now. And we know what works. We have to have the leadership, the investment, and the sustained effort to really see a reversing of these trends and to promote mental health and well-being for all communities in our nation. Now, a recording of this briefing and national webinar will be available along with the slides and the additional resources that we have been sharing. Those will be available on Trust for America's Health's website at tifa.org in the coming days. So I invite you to continue to visit our website for this information. Thank you again for joining us today. Be safe, be well, and take care. Thanks, everyone.